today I think we are very fortunate this afternoon that Dr. Prem has agreed to come and teach us on two things which I think all of us eventually should know, and I think there's varying degrees of confidence in our knowledge and skill on how to manage HFNCs. I think there was a recent publication also that just reiterated patients on HFNC versus patients on standard of care. Those on HFNC actually ended up less often being ventilated. So it, but anyway, so she will teach us on some of the management of HFNC, especially for patients who have a ceiling of care. Eventually we're going to, just put them on HFNC, and we need to know how to manage them, so that our ICU team can concentrate their resources on managing those that are in ICU. Okay, and I also, if time permits, then I think Dr. Prem would also talk to us on some of the treatments to improve patients' comfort in some of these patients who look like in there a lot of distress and may not be able to hold on even despite the HFNC. Yeah. So I'm Dr. Prem. For those of you who know, for those of you who don't know, she used to be in Hospital Sungai Buloh before she became a traitor, and now she's in UMMC. And she's very experienced as an intensivist, and one of the best people to learn from when it comes to intensive care for COVID patients. Yeah. Okay. I think without further ado, Prem, the stage is yours.
Thanks, Ben. Okay, I'm going to share screen, yeah, and let's see if I can. Do you see it now?
Yep.
Okay, so
can you be a bit bigger? Yeah.
Yes.
Slideshow. Yeah.
Sorry, slideshow, right?
Yeah. Need to go to slideshow.
Okay. Do you all see it now?
That's good.
Okay, excellent. All right. So I wasn't quite sure what exactly I should be talking about, because giving this type of talk to an anesthetist is slightly different than giving it to others. So I'm going to try and make it as simple as possible so that you guys can understand. And if there's anything at all that you don't understand, please feel free to stop me even during in between my slides, and you can ask questions. Yeah. Okay. So first and foremost, I think we need to get a few fundamental things sorted out first. Now, which is actually oxygen is bad. Okay, there have been more and more studies in the recent decade that say that oxygen is bad. Hyperoxia during CPR is bad for the outcome. Using high oxygen concentrations in patients with traumatic brain injury is bad. Okay, the outcome, patients' mortality is higher. Even in the ICU as such, ventilating patients in the ICU with very, very high FiO2s. In fact, even 0.4 is actually bad. Okay, so we are going towards more of conservative oxygen now. We even go down to 0.25%, which is what I am comfortable with. But literature has actually told us to go down to room air, to 0.21%. Imagine setting your ventilator to 0.21%, It is a bit difficult because, number one, it's been a long-standing culture of ours to always give patients oxygen. That's how we've grown, isn't it? Any patient who is okay, got pneumonia, but patient is not breathless, yes, slap that Resorption on. So that's the issue. Yeah. So it's yeah, bad habits difficult to change, isn't it? So if you look at this paper in BMJ, it was it's a rapid recommendation which was published in 2018. So what you need to know is it's of course a long-standing culture, like I said, difficult to change. Recent systemic review and meta-analysis has shown that too much supplemental oxygen increases mortality for medical patients in hospital. Okay. For patients receiving oxygen therapy, aim for peripheral capillary, which is pulse oximeter, of less than 96. It's a very strong recommendation. For patients with acute myocardial infarction or stroke, do not initiate oxygen therapy in patients with SpO2 of more than 90. So if they're 93, 94, just don't start it, leave it, they're fine. In fact, a target SpO2 range of 90 to 94 seems reasonable for most patients, and 88 to 92 for patients at risk of hypercapnic respiratory failure. So all those COPD patients, 88 to 92 is more than enough, is what is recommended. It is very conservative. It is very difficult, but we have to get there because this is very strong evidence. Okay. Can't I? Okay. All right. So in that same paper, so this is what the recommendations are. Recommendation 1, very strong. So you stop oxygen therapy if your saturation is higher than 96. Okay. Recommendation 2, which is weak, they suggest not starting oxygen between 90 to 92 saturations. And the recommendation 3, which is also very strong, do not start oxygen therapy at or above 93% saturation. So it has taken even me a very, very, long time and convincing to say, okay, I am comfortable with this number. However, there are conditions that that might benefit from higher or lower oxygen thresholds. Okay. Lower oxygen threshold, like I said earlier, the COPDs, patients with obesity, hypoventilation, they are also chronic CO2 retainers. Okay, patients with neuromuscular diseases like NMDs, patients with obstructive sleep apnea, or patients who have a decreased central drive. In these patients, a lower target is reasonable. And in patients with higher, in those whom you need to aim for higher targets are, burns patients who have been in an enclosed area, you are suspecting carbon monoxide poisoning, or patients with sickle cell crisis, patients with pneumothorax. Pneumothorax, the higher the FiO2 that you give, it resorbs faster. So in those kind of patients, definitely you would want to aim for higher. Okay. Now, other considerations, especially in our COVID patients, it is important to note that supplemental oxygen relieves hypoxia, but does not improve ventilation. So just because your saturation looks good, it doesn't mean that the lung mechanics is good. Okay, so saturation does not equal ventilation. So it does not. So when you give oxygen, it doesn't actually treat the underlying cause. Okay, so you still need to look at the patient and see how it is that they're breathing. The second point to consider is that saturation indicates oxygenation, not ventilation. Therefore, beware of the use of high FiO2 in the presence of reduced minute ventilation. So when the patient is not breathing so deeply, like in our COVID patients, they are all rapid, shallow breathers, So in them, the oxygenation, so they're oxygenating themselves. Two things can happen. One is either they wash out the CO2 to a point where they become drowsy, or they start to retain CO2. Carbon dioxide. Okay, so these two things can happen. So very careful when you're only monitoring saturation. The other considerations when you use oxygen, of course, CO2 narcosis, like I said earlier, and resorption atelectasis. Now, what happens is in resorption atelectasis, when you give high oxygen concentration, see, when you and I breathe in normal room air, only 21% is oxygen. Okay, so the rest of it is nitrogen. And nitrogen is not soluble. Okay, so it stays in your lung and keeps the alveoli open. So that's what makes your lung the FRC, the functional residual capacity. Your alveoli is all kept open by these non-absorbable gases. Okay, but when you use high oxygen concentration, what you do is you actually reduce the nitrogen content, and that way the oxygen in the alveoli, which is very highly soluble, carbon dioxide is more soluble, 20 times more soluble than oxygen. So the oxygen gets absorbed in the circulation, and then slowly the alveoli will slowly start to collapse. So it's recommended that do not use oxygen, high concentrations for too long. And pulmonary oxygen toxicity. So you know that these oxygen radicals that people talk about, when in a patient with damaged lungs, these oxygen radicals, they produce superoxide dismutase, it's called. And these actually cause further damage to the alveolar membrane. Okay, so whatever pathology is there, that is the fibrosis, you give oxygen, it actually worsens. It's something like what happens in paraquat poisoning, when there's lung fibrosis from paraquat. So when you give high oxygen, that actually escalates the damage in the lung. So similar things happen in patients with ARDS. So that is why we try to reduce the oxygen to less than 0.6 as fast as possible. And if you are having to use it for more than 48 hours, then expect these problems to happen to the lungs. Okay, so then shall we now say, and of course teach our nurses, which is also very difficult. I had such a hard time to get our nurses to change their mindset and target a saturation of 92 to 96. Okay, so 92 to 96 is fine. Okay, if you're not comfortable with 92, then maybe 93, since it's a strong recommendation. So 93 to 96 is more than enough. Commence oxygen therapy if your saturation is less than 92, and then start to wean off if it is more than 92. Do you all think you can do that? It's a bit difficult. Try getting our nurses, they're just so difficult with them. Okay, so now let's look at oxygen dilution. So why high flow nasal cannula, and why not just, whatever we've been using all this while, nasal prongs, our high flow mask, why not these? Okay, so if you look at normal tidal ventilation, okay, so when you and I breathe, our normal tidal volume is about 500 mils. And then in a minute, let's say you're breathing about 10 times a minute. So your minute ventilation is 5 liters, okay? That's what you're breathing at 21%. Now, in a patient who has COVID, they are breathing at 40, okay? Or at least 30, all right, 30. And imagine that the amount of flow that they need now. So it's not the normal 5 liters flow. If you're breathing at 500 mils tidal volume and at 40 breaths per minute, then you are actually requiring about 20 liters. So your high flow mask, the one with the rebreathing bag, that only allows you 15 liters max. Okay, so you are not able to give the amount that the patient actually needs. So that is why they deteriorate with the face mask and high flow mask. So you actually need to match, the flow needs to match the patient's demand. Okay, so that is the reason why you have to use high flow rather than this. Okay, so if you look at high flow, so okay, let's go back to the previous one. So if you see this explanation, if there is a nasal cannula at 6 liters per minute, delivering 45%, okay, but your patient is breathing 20 liters per minute at room air, which is what our COVID patients do, then what FiO2 do you think is actually reaching the patient's trachea? See, a patient who is breathless is not just breathing through his nose, he's also breathing through his mouth. You know, so both nose and mouth, and you put a nasal prong there in the nose. So whatever goes through the mouth is actually diluting whatever you are giving through the nose. Okay, so this phenomenon is known as oxygen dilution and will occur if you don't meet or exceed your patient's inspiratory flow demands. Okay, now if you put the patient on high flow, which is delivering 60 liters at 45%, okay, so with your patient still breathing at 20 liters at room air, so you would know that if you are going to set about 50% on the high flow nasal cannula, the amount that the patient gets, because the flow is so high through the nose, 60 liters is going in through the nose, through the mouth is not much now, you know, because there's more flow going through the nose. So you know that the concentration of oxygen that you're delivering is close to what you have said. There is some dilution, yes. In fact, it might be even more, you know, because if you're setting 50% on the high flow nasal cannula and then you're breathing extra 21% through the mouth, you may actually be giving more than what you have said. Okay, so that's the rationale behind it. Okay, so now looking at high flow nasal cannula or high flow oxygen therapy, we call it. So let's look at how it works. Okay, so what does it do? It provides the flow. Okay, FiO2, of course, we set it, but the two most important thing is it provides flow and it provides humidity, because this is humidified, heated. It's a heated humidifier, water bath that is set there, and so that is more, and it is set at body temperature, so it's definitely more physiological. So what does the flow do? It provides accurate oxygen delivery. It washes out anatomical dead space, and it also provides some PEEP. So the flow provides the PEEP, and so you know the alveoli is kept open, and the collapsed alveoli are also slowly recruited. Okay. Now the other part, the humidity part, what it does is it keeps the mucociliary structure intact, and so the function is also intact, and it is more comfortable for the patients. The secretions do not dry up. It is easier for patients to excrete whatever secretions that is accumulated. Yeah. Okay. All right. Okay. So let's look at the mechanisms. So we have the respiratory support. Okay, which is what it does is it reduces the dead space. There is dynamic positive airway pressure, which is your PEEP, and then patient is feeling comfortable. The airway is hydrated, and at the same time, it provides supplemental oxygen. Okay. So let's look at it one by one. Okay, so what is dead space? Now, to me, for an anesthetist, right, I think of dead space in three different categories. One is the instrumental dead space. Now, instrumental dead space, like for example, if a patient is intubated, it starts from the tip of the trachea. So all this device, yeah, all the way up to the Y piece of the ventilator tubing. Okay, so all these are actually air that is, or oxygen that is, gas that is delivered to the patient, and gas that is expired by the patient, which is not taking part in gas exchange. That is what dead space is. It doesn't take part in gas exchange. Okay, so all of this. So if you look at the tubing, right, the oxygen comes in through here, and then the expired gas goes out through here. So this one, there's no dead space here, but all of this, we consider it as dead space because all of these are wasted gas. Okay. In high flow nasal cannula, of course, the dead space will start from just in this place. So it's, you have eliminated the instrumental dead space if you use high flow nasal cannula. Okay. Now the second part is the physiological dead space, or anatomical dead space is what we call it. It is the dead space from the nose all the way up to the the second generation bronchus, which actually doesn't take part in gas exchange, okay, because the gas that is inhaled goes in here, and then the carbon dioxide mixed with oxygen comes out. So all of this part also doesn't participate in gas exchange. And this is about 150 mils of gas, okay, in anatomical dead space. And then the third dead space is the alveolar dead space, which is also very important in our COVID patients because all of them have this, okay. Alveolar dead space, when does this happen? Gas in the alveolus actually takes part in gas exchange. However, if there is a problem with the blood flow, like in COVID patients, they have pulmonary embolisms, they have multiple microthrombi everywhere, yeah. So when you have a clot sitting in the vessel around the alveolus, so that alveoli now becomes a dead space because the gas in that alveoli cannot move into the vessel because there is a clot sitting there. Okay, so that is the alveolar dead space. And that is what we are most of the time dealing with. And it is so difficult and it takes time, okay, because these are small microthrombi. And you must understand microthrombi, just like how, you know, when you hit yourself, you have a bruising in your skin. It takes about a week, 10 days, or even 2 weeks for it to resolve. So the same thing happens in the lungs. Any clot that forms takes about 2 weeks to resolve. So until then, your alveolar dead space is going to remain. Okay. So collapsed alveolus, if it is filled with mucus, also would behave like alveolar dead space, even though the vessels around it are normal. There will be some amount of gas exchange happening, but it is not optimal. Okay, so that is dead space. So how does our high flow nasal cannula behave now? It reduces dead space because the flow, the amount of flow given, it improves the recruitment of the alveolus and increases the functional residual capacity. Okay, so functional residual capacity is the gas that is trapped in the lung on expiration. So that means once you expire, your lung collapses, but that amount of gas remains. And that is the reservoir for the oxygenation of the patient. You know, when we intubate patients, you always see us pre-oxygenate the patient, right? With 100% oxygen. That is because we are trying to fill up this FRC with oxygen, so that in the event we fail to intubate or something, there is still oxygen reserve. And this FRC reserve can last up to, if it is well functioning, the oxygen reserve lasts up to 10 minutes. So you have a 10 minutes time for you to intubate the patient and establish airway. Okay, so that's the function there. So high flow nasal cannula is actually, it does recruit the alveoli, it increases the functional residual capacity, it reduces the rebreathing of gases of the anatomical dead space, which is from the nose all the way to the airway, the bronchus. So because the flow is so high, it washes out the CO2 and it fills it up with oxygen. So therefore, when the patient breathes out and breathes in again, because they are breathing very rapid and shallow, isn't it? So it's not a deep breath. So when you don't take a deep breath, the anatomical dead space gas is 150 mils. So there's a tendency to rebreathe the CO2 which is trapped in that anatomical space, okay? So by giving high flows and you wash out that, so when the patient rebreathes, they're actually breathing in oxygenated air. Okay, so that's how it helps to reduce dead space. Now, secondly, dynamic positive airway pressure is your peak. By increasing the lung volume, recruiting the alveolus, it actually gives the flow that continuously goes in, gives a continuous positive airway pressure in the alveolus and keeps it open. So with that, the tidal volume increases, once the tidal volume increases and oxygenation improves, respiratory rate will start to come down, and therefore there's improved alveolar ventilation and improved gas exchange. Okay, so as you can see in this diagram, patients with just 6 liters nasal cannula, what the lung looks like, and patients with high flow at 70 liters, what the lung looks like. Okay. Okay. So we talked about earlier about oxygen delivery, how in high flow it is more reliable. So because of the entrainment of air, when the patient is breathing through the mouth as well, the amount of air entrained through the nasal cannula, when the patient is on nasal prong, entrained through the mouth, there is a lot more room air, and so it is diluted. Whereas with high flow nasal cannula, you are able to deliver a more reliable concentration, or in fact more. Okay? And of course, like I said earlier, humidity, so it emulates the natural balance of heat and humidity in healthy lungs, enables the comfortable delivery of high flows, improves mucous membrane clearance, and prevents damage of alveolar epithelium. Okay. All right, so overall, it is very comfortable. It's an open system, so there's no, this tight mask around the patient. There's no injury, pressure sore, which can be quite distressing and painful. And if you see patients on CPAP, right, these patients just don't tolerate it. They're so uncomfortable. They're unable to speak. And every time they want to eat and drink, you have to take it out, and then they will desaturate and de-recruit. So high flow nasal cannula actually addresses all those problems. It's an open system. There's no seal required. There's no pressure source to deal with. There's less noise. There's just a little bit of hissing sound. So the patient is able to sleep at night. There's no alarm going on, tang, all the time, like, with CPAPs and with the ventilators. Patient is able to eat and drink. They can verbally communicate, not just with us, but with their loved ones, through the phone. And overall, there is improved tolerance. Okay. All right. So then, when do we start? Okay. So indications for high flow nasal cannula in adults is pretty much the same as when you start oxygen. All right. But when exactly, now community-acquired pneumonia, you slap that oxygen on them, but when do you decide that you have to change it to high flow? Is the question, isn't it? Now, for us, anesthetists, what we do is, or the intensivists, yes, we use it in pneumonias that come into us because they are more severe. Patients with who we have extubated, and we want to make sure that they do not get reintubated, so we put them on high flow. We also use it to pre-oxygenate patients prior to intubation because of the flow, and in ICU we don't have 10 minutes which we usually need to pre-oxygenate patients. So using a high flow nasal cannula, you can pre-oxygenate them in just 3 minutes. Okay. And then, of course, in patients whom we do not want to intubate, or who have decided that this is not for intubation, you can use them just to keep them comfortable. And then patients with cardiogenic APO, patients with APO, when NIV is not tolerated, you can use it in them as well. Okay. Now, so when exactly do we start? For that, you need to know this, okay, which is ROX index. Now, ROX index is respiratory and oxygen, it's a calculation where we use the saturation, you divide it by the FiO2 that you are giving, and the whole thing divide by respiratory rate. Okay. So this ROX index is very important to know whether this patient is going to deteriorate, number one. Number two, when to start high flow nasal cannula. Number three, whether using high flow nasal cannula is going to predict failure. okay, to predict failure of the HFNC. That means, is this patient going to be intubated? So we do this ROC score the moment the patient comes in ED. Okay, so it is measured at 2 hours, 6 hours, 12 hours. The number 4.88 is associated with success. So anything more than 4.88 is associated with success. Now let me explain further. Okay, so this is the graph that actually it has been validated. Patients on high flow nasal cannula, when they measure it at 2 hours, these are the numbers that they look at. Okay, so if it is less than 2.85, most likely this patient is going to fail. All right. If it is between 2.85 to 4.87, then you will have to increase the support and re-evaluate in 30 minutes. That means you increase the FiO2 on the high flow nasal cannula and re-evaluate in 30 minutes and decide whether, okay, is this patient now more stable, getting better, or getting worse? Okay. If it is more than 4.88, then we just continue monitoring. So the next, if you're continuing to monitor, the next one you do is at 6 hours. So you need to decide at 2 hours, 6 hours, and 12 hours. Okay, so the same thing, if it is less than at 6 hours, less than 3.47, you have to consider putting in, ventilating the patient. Between 3.47 and 4.87, you have to increase, and then between, if it's more than 4.88, we just continue monitoring. Again, at 12 hours, so is the same. Now, studies have shown that the most reliable of all this is the one at 12 hours. Okay, so if at 12 hours, any number less than this has shown to has been a better predictor of failure. Okay, so using high flow nasal cannula at 12 hours, if the number is less than 4.88, then they found that the patients definitely needed intubation. Okay, so do not delay after 12 hours. Okay. Now, okay, so this is a paper. Now, before COVID, this ROC score was used in patients with interstitial lung disease who were put on high flow nasal cannula, and then they decided, okay, looking at the ROC score at different timings, they decided whether this patient needs to be intubated or not. Right. Now, with the COVID, this ROC score has been used at many levels. One of the levels is at the ED. They did a study and they found that ROC score or ROC index was a better predictive, had a better, greater predictive validity than new score. So when you look at new score, it doesn't really tell you whether these patients are going to deteriorate or not, because most of the time our COVID patient are just that single lung, it's only the lungs. It's just a single organ problem. Whereas new score looks at everything else. So this ROX index was a better one. So when patients came in with room air, they did the ROX index, and then they decided, okay, this patient has got less than this, I have to put the patient on, maybe depending on the saturation, they started with face mask, and then they looked at it at 2 hours. If in that chart, according to the number, then they quickly escalated to high flow nasal cannula. So they used that very fast. I think for us, we probably lacking in that. We don't start them early enough. Okay, I think we tend to wait and wait. 15 liters high flow for 6-7 hours already. Then only we decide, okay, let's put them on high flow. So I think that's where we are going wrong. We should start them much earlier. So use that chart. Okay. Now, this is a very recent study which actually said the number 4.88 is probably not the right number for COVID. In fact, at 5.9, we should already be putting them on high flow nasal cannula. Okay. So this is a study that it's a multi-center. They did it in 3 centers. And they found that amongst all of their patients, 29% of them failed high flow nasal cannula and required intubation. And they found, when they did the ROC analysis, they found that 12-hour ROX index was the best predictor of intubation. And the best threshold was 5.99 with a specificity of 96% and sensitivity of 62%. Okay, so and in survival analysis, they found that a ROX value of less than 5.99 was associated with an increased risk of failure. So now we have to change that previous graph. That was based on interstitial lung disease patients, you know. So we just extrapolated that to use in our COVID. But looking at this study, it looks like we will have to change that number. Okay. All right. Okay, so looking at overall clinical key points would be, we have to use hyponasal cannula early. The moment your patient's respiratory rate is 30, more than 30, you know that the flow that they need is higher than what your high flow mask can provide. Okay, so you have to do it. You have to closely monitor them because you know that saturation is not equivalent to ventilation. So you have to look at other signs. Okay, look at the ROX index, look at use of accessory muscles, whether there is shock. Okay, lactate levels are very, very important. Look at how the neurology is. PF ratio, if your PF ratio is less than 150, then you know it's going to fail. You probably need to intubate them by then. Okay, so all of these things need to be looked at. Okay, so then moving on to the next part, which is comfort care. Now, you know, at the peak of the pandemic, the Malaysian Society of Intensive Care had to come up with this, okay, because we had to triage. We were overflowing. We had to make way for the younger ones. And so, you know, it was a very, very difficult situation at that point in time. I think you guys at Sungai Buloh know this better than anyone. So, you know, when MSIC came up with this, it was good for us, not good for you guys. Okay. I remember in January, I had an argument with Ben when there was an 86-year-old patient and I refused to bring him to ICU. And yeah, so this was what was going on. And yeah, it was, you know, but then at the peak of it, we had more and more of this type of decisions that we had to make. So yeah, you know, not good for you guys, because then you end up with all of these patients in there. It is easy for us to do comfort care and end of life care in the ICU, but doing it in the ward is not as easy. So this is from the NICE guidelines. Yeah, the NICE guidelines also came up with this, I think, because they also were dealing with so much of you know, what we were facing, probably 10 times more. Okay, so they came up with this consensus recommendation, and they have said, before escalating respiratory or other organ support, identify agreed treatment goals with the person, if possible, and their families and carers, or an independent mental capacity advocate, if appropriate. Start all advanced respiratory support or organ support with a clear plan of how it will address the diagnosis and lead to agreed treatment goals or outcomes. Okay, ensure this includes management plans for when there is further deterioration or no response to treatment. Okay, so this is the part which we had a problem with, you know. Usually patients come into the ICU, we have time limit. Okay, we normally speak to the families and give them time limited therapy. We tell them in 48, 72 hours, the patient should improve. If he doesn't improve, then we will have to relook and set limitations. Okay, but with COVID, they don't improve in 48, 72 hours. They take weeks. Some improve, some don't. So it was really very difficult to actually set this, you know. I found patients with same age, same comorbidities who improved in 6 weeks, and then the other one died in 6 weeks. So we just don't know where we are with this. So it is really very difficult. And this consensus recommendation is very vague. Okay. They do say do not continue respiratory or organ support if it is considered that it will no longer result in the desired overall goals. With COVID, we don't know. In 6 months, some patients come back, they are well, you know, so we really don't know, but they do not have the resources to go on ventilating patients for that long either. Okay. So it is definitely a lot more complex. You know, ideally, this is how it should be. You know, patient is in isolation. You have a palliative care team, primary care team, even the rehab there. You know, as a collective multidisciplinary team taking care of these patients, and then we discuss end of life care. Discussions with the patients and the family. Now patients are breathless. How do you go and talk about this to a patient who is drowning, right? And then the family, we can't meet them because of this, you know, they are not allowed to come in. Everything is via phone. Of course, we use technology, but it's not the same as being, you know, face to face and talking to them and making them understand. So it's a lot more complex. It is very difficult. So yeah, it's not easy. We had to undergo training on how to have conversations of end of life and all of that. And then now it's all just dumped on the primary team in the wards. It's definitely, I can understand the challenges. It's challenging without COVID. With COVID, it's even worse. Yeah. Okay. So now that you have patients in the ward, what can you do to keep them comfortable? Now, this consensus says opioids and benzodiazepines, which is what we always use too. But they have actually recommended the amount that NICE guideline recommends is something that is for patients with cancers, you know, patients with chronic diseases. For COVID patients, I find that the dosing that we give is actually not enough. All right. So of course, you know, you want to make sure that they are not distressed. So what we do is we actually start morphing sulfate. Morphing, we start at 5 milligrams per hour infusion. So in your 50 ml syringe, you dilute it to either 1 ml per, 1 mg per ml is our standard dilution. And then we start with, I usually titrate a bolus, okay, 1 milligram, 1 milligram, 1 milligram, up to 5 milligrams, and see how they are, and then start at 5 mg per hour, and then come back and look at them again and see whether they are going to be needing more or not. Most of the time, this is okay, but sometimes we do have to step it up to 10 milligrams per hour. Always mix, use a combination of midazolam as well. Midas, I usually start with 3 milligrams per hour and then slowly increase it. If you need to bolus it for comfort, go ahead, give small boluses and then titrate and see. What we want is for them to be comfortable and not, you know, thrashing around and not in pain. Of course, continue the high flow nasal cannula because that definitely helps to relieve the breathlessness. And some patients, they may feel nauseous, so antiemetics are good. Dexa is a good antiemetic. Of course, metoclopramide is the other one. And then laxatives, yeah, that's another thing, you know, when patients are unable to pass motion and they're breathless at the same time with abdominal distension, that can be quite distressing. So laxatives is something that you need to add on to these patients. What is the right number? There's no right number. There's no magic number to say this is the dose you use. No, you just have to titrate and increase and increase. I even go up to about 30 milligrams per hour But this is in ICU. So in the ward, you probably may not need that high. Yeah, okay, all right. And I think that's it. That's the end of the presentation. I hope I have answered your questions with the slides. But yeah, if anyone has any questions, anything you want to ask me about the management of these patients, please do. The working of the machine itself, the best thing to do would be to get the user training done. Okay, because I don't have the machine here, so it's difficult for me to show how to use it. But you can ask the ICU MAs to arrange for user training so that the company people can come in and show you guys how to do it. Yeah. Any questions?
Prema, thanks. Interesting that you talked about ROX. We tried ROX index initially, and then we gave up because, as you mentioned, the 4.88, because I think some of them are not tachypnic enough, they are hypoxic. I think you think the other one, the 5.88 would be a more reasonable number, is it? Because we were intubating patients way above 4.88.
Yeah. I think the higher. We also saw the same thing. We also saw that a lot of the patients who, some patients came in and we couldn't use the ROX score at all. They just needed to be intubated. But this ROX score is more for those patients whom, they need oxygen, you don't know whether they're going to deteriorate. So it's more for the more stable ones who eventually actually deteriorate. The ones that come in and are breathless, definitely straight away intubate. I don't even think that high-flow nasal cannula would prevent them from getting intubated. Yeah.
No, these are patients that technically in Ward 4C lab, they are struggling on high flow mask or something like that. We bring them in. Now we bring them earlier than before. Put them on HFNC. The question now is, do they need intubation or not? Or can we just carry on with this? So looks like the ROX index is useful to look at it, but it's just the cutoff that we are not sure of.
Yeah, so they're thinking it's a higher cutoff rather than from this study. Okay. But of course, not just the ROX index alone. I think we also need to look at the patient, the way they are breathing, because a lot of the times it is more of how they use their respiratory muscles. Those things also can influence the ROX. Because your saturation is okay, you see. The ROX, you calculate using saturation and the FiO2. So if the saturation is okay, you will actually get a higher ROX. So I think it's not just the ROX, it also is the clinical presentation of the patient. If the patient is looking, really, he may have a lower respiratory rate, but if he's using accessory muscles to breathe, and then he looks shut down and in shock. So I think those things also matter.
Hi, Dr. Prem, Hafiz here.
Hi.
Should we looking at the CO2 level as well? I mean, patients on
yes.
Yeah.
Okay, so when you look at CO2 level, you always need to look at bicarbonate as well.
Yeah.
Okay. Because the CO2 can go up as the bicarbonate go up. That's how the blood gas works. Your body works that way, it compensates, you see. So if you're giving patients Lasix can cause metabolic alkalosis, and the CO2 can go up as a result of the higher bicarbonate. And then of course, patients with chronic CO2 retention, they will already have high bicarbonates, 30s, 34, 35, like that. So they have a higher baseline of CO2. So if the patients who have pre-existing metabolic alkalosis, they should have a higher CO2 to begin with. If it doesn't correlate, then there's something not right there. Okay. Of course, with COVID, as the lung gets worse, there is a problem with diffusion, then the CO2 will start to go up, because the carbon dioxide just cannot come out of the blood and into the alveoli, because the alveoli itself is damaged. It's thickened already. You know, so there's no, so those are end stage lungs. They in my setting, I've not seen this kind of CO2 patients, you know, on high flow. Okay, we didn't want to intubate. I don't know whether you all, okay, never mind, I won't tell who the patient is, but he was a doctor. And we didn't want to intubate because he was GCS so good and he was looking comfortable. His ROX index was fine, but the CO2 continued to go up. It was at 78, you know, 70 something around there, but he was so clear-minded, you know, and we were thinking, oh my God, what's going on, you know? But it's just the lung. The lung was just getting damaged, and the CO2 was the clue. You know, he was progressing to end stage. And then finally, when he started to become narcos, we had to intubate, but it was the stiffest lung to ventilate. It was just so stiff. And we went on and on for a month like that, and he just couldn't recover.
And then the other question is that once a patient is on high flow nasal cannula, let's say they're required to do CT scan or something. So for that short time period, we'll switch them to high flow mask lah. Because it's not
okay. You know, your high flow nasal cannula, you can fix it to the oxygen tank.
Cylinders. Okay.
Yeah. So you can actually bring them with the tank. You know.
But I think it's only lasting for 15 minutes, just enough for the procedure to be done.
The tank can last for 2-3 hours. That one not an issue.
Okay.
It's just that you need to get that head, you know,
the adapter connector. Yeah. Okay.
The adapter, yes, that one.
Dr. Suresh, we are putting face masks on these patients, right? I mean, for the fear of
aerosolization.
It is a common practice, isn't it? I mean,
yeah, I guess all of them, you know, anyone with risk of aerosolization, we should put the face mask on. Okay. That in fact will improve the oxygen because there's no dilution, you know, from room air. There's less dilution from room air. In fact, it will actually help to improve.
All right. Okay. Thank you.
Do you actively advise them to keep their mouths closed?
We do try because some of them they breathe through the mouth, you know, and you can see the desaturation happening because the flow is so high that, you know, the flow goes in through the nose and comes out through the mouth when the mouth is open. So I've had patients like that as well. Yeah, and it's not easy, lah.
Sorry, Premela. So in increasing CO2 in a ventilated patient, let's say we rule everything out, can also mean that this lung is actually becoming stiff. Is that, yes. Yeah.
That's what so that's what I found, that, you know, because when the lung is stiff and then you are unable to wash out the CO2 because we can't ventilate them, you know, the peak pressures are high, the tidal volumes are so low, you know, with just 200-300 mils of tidal volume, the peak is like 40-50. So it's a very stiff lung. And when you cannot ventilate them effectively, it's hypoventilation. So CO2 starts to climb. That's one thing. Second thing is the diffusion itself is a problem. So the alveoli damage, it becomes fibrosed, and so the gas just cannot move, you know, across the membrane from the blood into the alveolus. It just can't, and so it remains in the blood, and that's how the CO2 goes up as well. Because a lot of the times, our Lasix, so it's us induced in those patients, then we give acetazolamide and then it reduces again.
Sorry, Lasix does what? Sorry, then didn't.
Lasix causes metabolic alkalosis.
Oh, all right. Okay.
So when your bicarbonate goes up, CO2 will also go up. In them, the pH you will see will be alkalimic. It won't be acidotic. The pH will go up to 7.5.
So it's more metabolic component rather than the.
So in them, I usually give acetazolamide, and that will bring down the CO2 along with the bicarbonate.
Right. But the patients that I'm talking about are the ones where metabolic alkalosis is not the issue.
Them,
that's the lung bad, right?
Yeah. So in those are the patients where we actually withdraw, we withhold escalation.
Sorry, Premela, I think we need to cover weaning HFNC. Would you bring down the pressure support first or the FiO2 first?
Okay. All right. Because it's the flow that is needed, so it will be the FiO2 that comes down. If you look at our venti mass, right, 50% venti mass, that is 15 liters, isn't it? So what I usually tend to do is I will bring down the FiO2 to about 50%. And if they are okay, the gas exchange is acceptable with that, then I slowly bring down the flow to see if I can bring it down to up to the venti mass of 50%. So the flow, bring it down to 15. If they're tolerating with that 15, then switch to venti mass kids. Yeah. But do you all use venti mass in the wards? You do, right? Yeah. So because that way you know how much of the FiO2 that you are delivering. It's easier than the face mask or the high flow mask, because those are variable. We really don't know how much we are delivering. So, but in some of them, it's really difficult. It takes days before we can even come down. So as long as the sets are above 92, we just continuously. I bring it down by 5 usually. So like if the patient is on 60%, then I try to bring it down to 0.55, and then I bring it down to 0.5, like that. So slowly. I don't bring both down together. It's one at a time. FiO2 first up to 0.5, and then slowly bring down the flow to 50. And then see if I can bring it down further or not. If the flow is okay, so if I can bring it down to 30 is also, then you start on the FiO2.
Sorry, Prem,
For weaning, I don't go according to the rocks. Actually, they are doing studies on using rocks to wean as well. I just go by saturation. It's a lot easier.
Sorry, Prem, I'm not sure whether you covered it earlier because I had some phone calls in between. What is the maximum that you give for high flow nasal cannula?
Okay, so again, depends on, see, if this patient, you think it's good outcome, then 0.6 is max. Anything beyond that, I would intubate. But if this patient is not for intubation, then we just continue to increase so that the patient is comfortable. So it can go up to 1.
Because when you said that right at the beginning with high oxygen is bad, is bad in the short term or is bad in the long term?
Okay. So in medical patients, they found that the outcome, mortality, number 1, and organ failures, especially the brain, these are bad. Sorry, Ben, did I answer your question?
Sure. No, that is just because you started off by saying how poisonous oxygen was, and so that's why I'm just curious, Yep.
Yeah, actually, right now in we are participating in a multi-centered study called Mega Rocks. It is we've categorized our patients to liberal group as well as conservative oxygen therapy. So that will give us more answers. But now the current evidence is whenever they looked at certain groups of patients, like those who have undergone CPR, those who had CPR, patients who, were used, 100% oxygen was used in them, they had worse mortality compared to those who were, more conservative. So they only used aim for a saturation of 94 compared to 98, and the 94 group did better than 98. So that's what they saw. And then even in traumatic brain injuries also, patients undergoing surgeries, in the operation theater, they found that when you use conservative, the patients did better than the liberal group. Like that, even in medical ICUs, they found that patients with conservative had better outcome than, so they looked at mortality most of the time. They had better outcome compared to the liberal group. So that's why this rapid recommendation, because it looked like conservative was a better thing, and we were unnecessarily using high oxygen, and I think the oxygen radicals were actually causing organ damage more than, yeah. Well, what are the practical problems that you all face in the wards? The weaning part, is it?
Weaning part is probably one of the biggest this one that we have lah. Weaning patients, and sometimes using very high flow oxygen, 60, and then sometimes the FiO2 goes up to 1.0, and patients are left on it. But it's happening less now because the volume of patients who are deteriorating are lower compared to what it was before. Yeah, we're just wondering whether that is doing more harm, whether it's better to just intubate patients.
Yeah, so definitely FiO2 more than 0.6 is known to cause more harm, especially if you use it for prolonged periods. So if the patient is requiring more than 0.6, even after 24, 48 hours, you cannot bring it down, then you are actually causing more harm. So in those patients, best is to intubate them early. So that's why my cutoff is 0.6. The moment I reach 0.6, I will intubate. If I require more than that lah. If it remains at 0.6, I just wait and see. But anything more than that, we usually intubate, because we know it's not going to help, and it's going to cause more harm because of the resorption itself. The alveoli is all going to collapse. Yeah. So yeah, when the volume is high, of course, you have no choice now. You're running out of ventilators. So you just have to buy time and use this. But most of the time, if the patient is requiring higher and higher and higher, then your therapy is failing. So you have to change modes already. Yeah. The weaning part, like I said, different patients, some you can really wean very fast, some just take their own sweet time. So do the anesthesia team come to the wards to?
Yes, they do. Yes, they do.
They do. Okay, so that's what we used to do as well. At one point, when we had all ventilated patients in the ICU and all the high flows, we kept them in the wards, and I sent a team there every day to go and help to wean, and so we did the weaning part for them. Yeah, but some of them took long. They took 2-3 weeks to be weaned. That also can happen. So you just have to sit on them and go slow.
Right. And some patients are on another problem that we have is some patients they tend to be on HFNC for a very long time. Like you said, it's very slow weaning. But there may be a transient improvement, but the PCO2 goes up. I think we discussed this. It's possible that the lung is actually getting stiff.
Yes,
isn't it?
We've had that as well. We've had patients who got better, weaned off the oxygen, and then after, about a week or so, deteriorated, came back, and that's, I don't know what strain that was, but that quite a few patients came back like that. And it's really sad because once they come back and we had to intubate them, that's it. It was just stiff lung and nothing could be done.
Hi, Dr. Prem, I'm Chang here. Dr. Prem, I would like to ask, do you routinely wean based on the SpO2 or the arterial blood gas?
Okay, so because we have the luxury of an arterial line, I use arterial line. But in the ward, there's no reason why you shouldn't be able to use the pulse oximeter. Unless you have some saturation gap, like methemoglobin or something like that that's causing a problem. Usually the SpO2 and SaO2, the difference is not much. So you should be able to use the pulse oximeter. But if you do have the luxury of doing blood gases, why not? What other practical problems, guys, do you all have? What do you face? A lot of the time, it's just the frustration of, unable to do anything. You go today, you see them stuck on that. If I were to next day, you go, so same. Our tendency is, yeah, we want to do something, but yeah, sometimes you just have to sit on them and just let them do what they are going to do, Yeah, so don't rush to wean. You just have to keep an eye on whether they are deteriorating. If they're not deteriorating and if they're stuck there, it's okay. Just leave them there. Eventually, they will, hopefully they come out of it.
Anything else?
Dr. Prem, I think there's some anesthesia paper early on talk about the phenotypes, different phenotypes of
yes.
COVID. I mean, are there any difference in terms of the ventilation strategies in using nasal cannula?
Oh, high flow, no. That is more for mechanical ventilation. So we have the L type, the low elastance and the high elastance lungs. That's how we ventilate. We categorize the patients. Is this a low elastance problem or a high elastance problem? And according to that, our ventilator strategy or settings will differ. With high flow nasal cannula, no, there's no difference there.
Okay, I think Ben is on call. I think he must be on the phone or something.
Okay.
Thanks, Premela. I think you have answered many of our questions. I think, of course, your first point is important. I think it will change our practice. We won't be chasing the SpO2. We'll try not to chase the SpO2 as much as you're suggesting. Can you hear me?
Yes. Ken.
Yeah. We will try that. Thanks, and we will continue to call you for other questions that we have. Is that okay? Can we, if we all okay with that, can we close the session? And thanks, Premela. Thanks.
All right. Thank you.
Thanks, Prem. Thanks.
Yeah, thank you.
My pleasure.